Okay, let's unpack this. Today we're embarking on a really fascinating deep dive into one of the most vital organs in the body.
The heart.
Exactly, the heart. From its intricate architecture to its incredible pumping power, even its deep roots in culture, we're going to explore what makes it tick, literally and figuratively.
That's right. And we're drawing from two pretty comprehensive sources today, a detailed Wikipedia excerpt and an anatomy guide to really pull out the key insights.
Good stuff.
Yeah, the mission is to give you a clear, thorough understanding, but, without getting totally bogged down in information overload.
Perfect.
You should get some surprising facts, maybe a few aha moments, and leave feeling, well, pretty well informed.
So let's kick off with the basics. Where exactly is this incredible organ located, and what does it look like? I always sort of thought it was just, on the left side of the chest.
Yeah, that's a really common
Oh,
misconception.
really?
Yeah.
Yeah.
While its apex, the pointy bit at the bottom, does point over to the left.
Mhm.
And yeah, the largest part of it is a bit offset that way. The human heart is actually situated right in the middle of your chest.
Smack in the middle.
Right in the center, yeah.
Yeah.
In the thoracic cavity, tucked right there between the lungs.
Wow.
It's in this space called the mediastinum, specifically around the level of your T5 to T8 vertebrae.
Okay.
And its front surface is just behind your sternum, your breastbone, and the rib cartilages.
So it's really protected then.
Exactly. And because of the heart's position, your left lung is actually a bit smaller than the right one.
Huh.
Yeah, it has this little indent, a cardiac notch, specifically to make room for the heart.
That's a neat detail. So the heart's position actually influences the lung's shape. That's fascinating interplay.
It really is.
And what about its size? I've heard that size of a closed fist analogy a lot. Is that accurate?
It is often described that way, yeah.
Yeah.
Roughly 12 centimeters long, 8 centimeters wide, 6 centimeters thick,
Yeah.
weighing between 250 and 350 grams in adults. But it's worth noting that description is actually debated a bit. Your heart is probably a little larger than your fist.
Right.
And for well-trained athletes, it can be significantly larger.
Ah, because it's a muscle, it grows with exercise.
Precisely. Just like your biceps would respond to training, the heart muscle hypertrophy gets bigger and stronger with endurance exercise.
Okay, this is where it gets really interesting for me. What is the heart actually made of? And what protects it beyond the ribs?
Good question. So the heart is wrapped up in this double membrane sac. It's called the pericardium.
Pericardium.
Yeah, think of it like a protective bag. It has a tough outer fibrous layer and then this double inner serous membrane.
Double layer inside.
Yeah, and it produces pericardial fluid. Just a small amount, but it's crucial.
Why is that?
It acts like a lubricant. It lets the heart beat and move smoothly against other structures in the chest, reduces friction. It also helps keep the heart anchored in position and protects it from infection spreading. And then the heart wall itself has 3 distinct layers.
3 layers.
Yep. The innermost one is the endocardium. It's a super smooth lining made of simple squamous epithelium.
Like the inside of blood vessels.
Exactly. It's continuous with the lining of your blood vessels, covers all the chambers and valves, makes your blood flow smoothly. It can even help regulate how the middle layer contracts.
And that middle layer, that's the powerhouse, right? The muscle.
Precisely. That's the myocardium. It's the thick, muscular part that does all the heavy lifting.
Myocardium. Got it.
It's an involuntary striated muscle tissue, meaning you don't consciously control it, and it looks striped under a microscope. It's surrounded by a collagen framework, giving it structure.
And how is it structured? You mentioned it pumps effectively.
Well, what's fascinating here is the pattern of the muscle cells. It's not just straight fibers. They have this elegant, complex, swirling pattern.
Swirling.
Yeah, they spiral around the heart's chambers. Imagine trying to wring out a wet towel, you twist it, right?
Yeah, much more effective.
Same idea. That twisting motion allows for incredibly effective blood pumping, squeezing the blood out efficiently. And about 99% of these cells are the contractile ones, the ones that actually squeeze.
Okay.
They're connected by these special junctions called intercalated discs. These let electrical signals pass really quickly from cell to cell.
So they all contract together.
Exactly. It makes the heart act like a single coordinated unit, a syncytium, the remaining 1%. Those are the pacemaker cells.
Ah, the ones that set the rhythm?
Yep, they form the heart's conduction system.
Yeah.
And they have this unique ability called autorhythmicity.
Meaning they generate their own electricity?
Basically, yes.
Hmm.
They initiate their own electrical impulses at a fixed rate, setting the pace for the whole heart. And finally, The outermost layer of the actual heart wall is the epicardium,
Epicardium.
which is essentially the inner visceral layer of that pericardial sac we talked about earlier. It's kind of fused to the heart muscle.
Okay, so it's this incredibly structured muscular pump with protective layers. But how is it organized inside to make sure all that blood goes where it needs to go?
Right, the internal architecture is key.
Yeah,
We connect this to the bigger picture. The heart is divided into 4 chambers.
4 chambers.
2 upper ones, the receiving chambers, called atria, and 2 lower ones, the pumping chambers, called ventricles.
Atria and ventricles.
Yep. And for simplicity, we often talk about the right atrium and right ventricle together as the right heart, and the left atrium and left ventricle as the left heart.
Okay, can you walk us through these chambers? What does each one do?
Certainly. Let's start with the right atrium. This is the first stop for deoxygenated blood coming back from your body.
From the veins.
Exactly. Via 2 big veins, the superior and inferior venae cavae. And even a small amount from the heart's own circulation comes back here through the coronary sinus.
Okay.
Inside the right atrium, there's a cool little feature, an oval-shaped depression called the fossa ovalis.
Fossa ovalis.
Yeah, it's actually a remnant, a leftover from an opening that existed in the fetal heart before birth.
Wow.
The right atrium then connects down to the right ventricle, and the blood passes through the tricuspid valve.
Tricuspid, 3 flaps.
3 cusps, or flaps, exactly. Now, the right ventricle's walls aren't smooth inside. They're lined with these muscular ridges called trabeculae carneae.
Trabeculae carneae.
Sounds complex.
It just means meaty ridges. They probably help with contraction strength. And the right ventricle has this unique band of muscle called the moderator band.
Moderator band, what does that moderate?
It's actually crucial for cardiac conduction. It carries part of the electrical signal across the chamber. It helps coordinate the contraction, reinforcing the ventricle's relatively thin walls before it tapers up into the pulmonary trunk, ready to pump blood to the lungs.
Okay, so that's the right side, handling the deoxygenated blood.
Yeah.
What about the other side, where the oxygenated blood comes back?
That's the left heart. So the left atrium receives that fresh, oxygen-rich blood coming back from your lungs.
Through the pulmonary veins, exactly. Usually 4 pulmonary veins empty into the left atrium. It then connects down to the left ventricle through the mitral valve.
Mitral valve, also called the bicuspid valve, right? 2 flaps.
Correct. Bicuspid for its 2 cusps. Now, the left ventricle, this is the real powerhouse of the heart.
Because it pumps to the whole body.
Precisely. Its walls are significantly thicker and more muscular than the right ventricle. It needs to generate much greater force to pump blood out through the aorta to your entire body.
Makes sense.
It also has those trabeculae carneae, the ridges, but it lacks that moderator band found in the right ventricle.
Sure.
And there are 2 small but vital openings just above the aortic valve where the blood leaves the left ventricle.
What are those?
Those are the openings for the coronary arteries, the vessels that supply blood directly to the heart muscle itself.
Right.
The heart feeds itself first, essentially. Now, separating these chambers are crucial walls, or septa. The interatrial septum is between the 2 atria, and the interventricular septum is between the 2 ventricles. And that interventricular septum is notably thick and muscular, again, reflecting the high pressure the ventricles, especially the left, have to handle.
So the walls reflect the workload.
Absolutely. And underlying all this is a fibrous cardiac skeleton.
A skeleton inside the heart.
Sort of, yeah. It's a dense connective tissue framework. It provides structural support, anchors the valves. But importantly, it also acts as an electrical insulator.
So the electricity can only travel through specific pathways.
Exactly. It forces the electrical impulses coming from the atria to go through the designated conduction system pathway, ensuring the ventricles contract only after the atria have finished.
You mentioned valves several times, tricuspid, mitral. They sound critical. What's their precise role again?
This raises an important point about directional flow. Their role is absolutely vital. They act like one-way gates.
To prevent backflow.
Exactly. There are 4 valves, and they ensure blood flows in the correct direction through the heart chambers and out into the arteries, preventing it from leaking backward. So between the atria and ventricles, you have the atrioventricular valves, or AV valves.
The tricuspid and mitral.
Right. On the right side, the tricuspid valve with its 3 cusps. On the left, the mitral or bicuspid valve with its 2 cusps.
And they have those little cords attached.
Yes. They're connected by these strong fibrous cords called chordae tendineae, often called heartstrings.
Heartstring.
Yeah. And these cords attach the valve cusps to small muscles protruding from the ventricle walls called papillary muscles.
Papillary muscles. And they do what?
They are absolutely vital. When the ventricles contract forcefully, these papillary muscles also contract, pulling on the chordae tendineae.
To hold the valves shut.
Precisely. It prevents the valve cusps from being blown backward up into the atria like an umbrella flipping inside out in the wind. It ensures a tight seal.
Clever design. And the other two valves, the ones at the exits.
Those are the semilunar valves. They're located at the exit of each ventricle, where the blood leaves the heart.
Okay.
You have the pulmonary valve at the base of the pulmonary artery, leading from the right ventricle.
To the lungs.
Yep. And the aortic valve at the base of the aorta, leading from the left ventricle.
To the body.
Right. Both of these typically have three small pocket-like cusps.
Pocket-like.
Yeah, they look like little half-moons, hence semilunar. And unlike the AV valves, these are not attached to papillary muscles or chordae tendineae.
So how do they close?
They close passively. When the ventricles finish contracting and start to relax, the pressure in the pulmonary artery and aorta becomes higher than in the ventricles. This back pressure pushes blood back towards the heart, and that backflow catches inside those little pockets, snapping the cusps shut and sealing the valve tight. Prevents blood leaking back into the ventricles while they refill.
Okay, so we've got the blueprint. Layers, chambers, septa, valves. It's intricate. Now, how does this all work together second by second to actually move the blood? Can you maybe walk us through the journey of a single drop of blood?
Absolutely. It's a fantastic journey to trace. The heart's main job, its primary function, is to act as this relentless pump in a continuous circulatory system.
Right.
And that system has two main circuits, remember. The systemic circulation
Your body?
and the pulmonary
It's
circulation.
the lungs.
Exactly. So let's imagine a drop of deoxygenated blood, blue blood if you like, returning from, say, your big toe.
Okay, long journey back.
It travels up through veins, eventually reaching one of the big venae cavae, and enters the right atrium.
First chamber.
First stop. When the right atrium contracts, it pushes this blood down through that open tricuspid valve into the right ventricle.
Filling the right ventricle?
Yep. Then the right ventricle contracts forcefully. As it does, the tricuspid valve snaps shut, bang, preventing backflow into the atrium. And the pressure forces the pulmonary valve open, propelling that deoxygenated blood into the pulmonary trunk.
Heading for the lungs.
Correct. This trunk quickly branches into pulmonary arteries, taking the blood right into your lungs.
And that's where the crucial exchange happens, right? Getting rid of waste, picking up oxygen.
Precisely. In the lungs, within tiny capillaries surrounding the air sacs, or alveoli, the magic happens. Carbon dioxide diffuses out of the blood into the air you'll exhale, and oxygen diffuses from the air you just inhaled into the blood.
Yeah.
It's a passive process, just driven by concentration differences.
Simple diffusion. Amazing. So now our blood drop is oxygenated, red.
Exactly. Now, bright red and oxygen-rich, it returns from the lungs to the left atrium via those four pulmonary veins.
Back to the heart, left side this time.
Yep. The left atrium contracts, pumping the blood down through the open mitral valve into the powerful left ventricle.
Filling the big pump.
Right. Then the left ventricle contracts with immense force. The mitral valve slams shut, and the sheer pressure forces the aortic valve open, injecting that oxygenated blood into the aorta.
The body's main highway.
The biggest artery, yes.
Yeah.
From the aorta, it branches into smaller and smaller arteries, then arterioles, and finally into capillaries spread throughout your entire body, back down to your big toe, for instance.
Delivering the good.
Delivering oxygen and nutrients to all your cells for metabolism. And in return, it picks up carbon dioxide and other waste products.
So now it's deoxygenated again.
Back to blue. This deoxygenated capillary blood then flows into tiny venules, which merge into larger veins, eventually collecting back into the superior and inferior venae cavae,
And back to the right atrium.
returning to the right side of the heart to begin the whole journey all over again.
Wow. That is an incredible symphony of events happening constantly.
Continuously, with every single heartbeat. It never stops.
It really puts into perspective what's happening inside us all the time. What do we call this entire sequence? The contraction and relaxation, the filling and emptying?
That whole sequence of events that occurs with every single heartbeat is called the cardiac cycle.
The cardiac cycle? Okay.
It describes everything that happens. The period when the ventricles are contracting and forcing blood out. That's called systole.
Systole, like systolic blood pressure.
Yeah, exactly. And the period when the ventricles relax and refill with blood. That's diastole.
Diastole.
Got it. And the atria and ventricles work in perfect coordination, but sort of in opposition. When the ventricles are in systole, contracting, The atria are in diastole, relaxed and filling up.
Ah, so they take turns being active.
Precisely.
Yeah.
It ensures continuous flow. So at the start of a cycle, your ventricles are relaxing in diastole. Blood is flowing passively from the atria through the open AV valves, tricuspid and mitral, into the ventricles.
Filling up.
Then the atria contract atrial systole, giving a final little squeeze to top off the ventricles, priming the pump.
Okay.
Next, the ventricles begin to contract ventricular systole. As the pressure inside them rises, it quickly exceeds the pressure in the atria, snapping the mitral and tricuspid valves shut.
That's the lub sound.
That's the first heart sound, S1, the lub, yes. For a brief moment, all 4 valves are closed as pressure builds.
Right.
Then, when the ventricular pressure gets higher than the pressure in the aorta and pulmonary artery, the aortic and pulmonary valves are forced open.
Whoosh, blood ejects.
Blood is ejected forcefully into those arteries. As the ventricles empty, the pressure inside them starts to drop. When it falls below the pressure in the aorta and pulmonary artery...
The exit valves close.
Exactly. The aortic and pulmonary valves snap shut due to the back pressure. That's the second heart sound, as to the dub.
Lub-dub, lub-dub.
Makes sense now. Then the ventricles continue to relax, ventricular diastole, pressure drops further, the AV valves, mitral and tricuspid, open again, and ventricular filling starts all over. The whole cycle repeats.
It's incredibly efficient. This raises an important question, though. How much blood are we actually talking about here? How much does the heart move?
That's a great question. How much blood does the heart pump?
Yeah.
Well, that brings us to something called cardiac output,
Cardiac output.
which is the amount of blood pumped by each ventricle in 1 minute. Remember, both ventricles pump the same amount over time.
Okay, how do you figure that out?
It's pretty simple, actually.
Sure.
You multiply the stroke volume.
Stroke volume.
Yes, that's the amount of blood pumped out by a ventricle with each single beat.
Okay.
You multiply that by the heart rate, the number of beats per minute.
Stroke volume times heart rate.
Exactly. So, on average, let's say an adult stroke volume is about 70 milliliters.
70 milliliters per beat.
And a resting heart rate might be, say, 75 beats per minute.
Okay.
So 70 millilol times 75 beats per minute gives you 1,550 millilol per minute, or 5.25 liters per minute.
5.25 liters every minute.
Every minute at rest. That's roughly your entire blood volume circulating through your body every single minute.
That is astonishing.
It really is. And the normal range is quite wide, maybe 4 to 8 liters per minute. It can be influenced by many things: heart size, your physical condition, mental state, even sex. And 2 key factors that influence that stroke volume, how much blood is pumped per beat, are preload and afterload.
Preload and afterload. Okay, what are those?
Think of preload as the stretch on the heart muscle just before it contracts. It's related to how much blood is filled the ventricle at the end of diastole.
The more it fills, the more it stretches.
Exactly. And there's this amazing principle called the Frank-Starling mechanism.
Frank Starling.
Yeah. It basically says that the force of the heart's contraction is directly proportional to how much its muscle fibers were stretched at the beginning. So the more blood that comes in and stretches the ventricle up to a point...
The harder it pumps it out.
Precisely. It's like stretching a rubber band further. It snaps back with more force. It allows the heart to automatically adjust its output to match the amount of blood returning to it.
Ingenious. And afterload.
Afterload is the resistance the ventricle have to overcome to eject blood out into the artery.
Ah, like the pressure in the aorta.
Exactly. It's the pressure the heart has to push against. High blood pressure, for instance, increases afterload, making the heart work harder. Narrowed valves can also increase afterload.
So preload is about filling, afterload is about ejecting against resistance.
You got it. And the actual strength of those contractions, the contractility, can also be influenced by certain substances. We call them inotropes.
Inotropes.
Yeah. Positive inotropes increase the force of contraction. Think adrenaline, noradrenaline, dopamine, the stuff that kicks in when you're exercising or stressed.
It gives the heart an extra boost.
Right. Negative inotropes decrease the force of contraction. Certain medications, like some calcium channel blockers, act as negative inotropes, perhaps to reduce the heart's workload.
It's just amazing how the heart coordinates all this pumping, adapting to preload and afterload. But it must need its own dedicated fuel supply to keep going 24/7, right?
Yeah.
How does the heart muscle itself get oxygen and nutrients?
You're absolutely right. It's working constantly, needs a constant energy supply. Like all cells in your body, heart tissue needs its own steady stream of oxygen and nutrients, and a way to get rid of waste products like CO2.
Makes sense.
This is handled by its own dedicated circulatory system, the coronary circulation.
Coronary circulation, like the coronary arteries you hear about?
Exactly. Blood is supplied to the heart muscle by two main coronary arteries that branch off right from the very beginning of the aorta, just above the aortic valve.
So the heart gets the first dibs on oxygenated blood.
Pretty much. You have the left main coronary artery and the right coronary artery.
Right.
The left main quickly splits into two major branches. The left anterior descending artery, or LAD.
The widowmaker artery, sometimes called that.
Unfortunately, yes, because a blockage there can be so critical. It supplies the front, the outer side, and the septum of the left ventricle. The other branch is the left circumflex artery, which wraps around to supply the back and underneath of the left ventricle.
Okay, so the left artery covers most of the big pumping chamber.
Largely, yes. Then the right coronary artery supplies the right atrium, the right ventricle, the bottom part of the left ventricle, and importantly,
Yes.
it also usually supplies blood to the heart's natural pacemakers, the AV node in about 90% of people, and the SA node in about 60%.
Wow, so a blockage there could affect the heart's rhythm too.
It certainly could. It highlights how crucial this coronary circulation is.
So it has its own dedicated blood highway system delivering fuel. What about taking out the trash? The drainage?
Good point. Most of the deoxygenated blood from the heart muscle itself doesn't go back through the main veins. It collects into cardiac veins, which then drain into a large vein on the back of the heart called the coronary sinus.
Coronary sinus.
And this coronary sinus then empties directly back into the right atrium, mixing with the deoxygenated blood returning from the rest of the body.
Ah, so it rejoins the main circuit right there.
Exactly. Some smaller veins drain directly into the right atrium too. And there are also intricate lymphatic networks within the heart layers that help manage fluid balance.
Okay, that covers the plumbing, but the beating itself, you mentioned pacemaker cells earlier. How does the heart generate that incredibly reliable rhythm beat after beat?
Right, the electrical system, it's incredibly elegant. The normal, regular heartbeat is called sinus rhythm,
Sinus rhythm.
and it's established by the heart's primary natural pacemaker, the sinoatrial node, or SA node.
SA node, where is that?
It's a tiny cluster of specialized cells located in the upper part of the wall of the right atrium, near where the superior vena cava enters. This is where the electrical spark is spontaneously generated.
The starting point.
The starting point. These SA node cells are unique. At rest, they have a negative electrical charge inside compared to outside.
Okay.
But then ions, particularly sodium ions, start to leak in, making the inside less negative. When it reaches a certain threshold, bang, voltage-gated channels open, sodium rushes in rapidly, making the inside positive. That's depolarization, the electrical firing.
The zap?
The zap, exactly. Then calcium ions flow in, which is crucial for sustaining the contraction, followed by potassium ions flowing out, which brings the charge back down to negative repolarization, getting it ready to fire again.
And it just does this automatically?
Automatically, rhythmically. What's fascinating here is the role of calcium. Its influx through slow channels gives these pacemaker cells, and also the regular heart muscle cells, a prolonged plateau phase where they stay positively charged.
Plateau phase.
Yeah, it's important. It prevents the heart from trying to contract again too quickly, allowing time for it to relax and refill properly. And calcium, of course, is also the key ion that interacts with the muscle proteins to actually trigger the physical contraction and relaxation.
So the SA node kicks things off. What's the path that electrical signal takes to make the whole heart beat in sequence?
Great question. The signal doesn't just stay in the SA node. It spreads out radially, like ripples on a pond, through the muscle cells of the right atrium.
Okay.
And it travels across to the left atrium via a special pathway called Bachmann's bundle.
Bachmann's bundle.
This ensures that both atria contract pretty much simultaneously, pushing their blood down into the ventricles.
Right. Atrial contraction first?
Then, the signal converges on another crucial node, the atrioventricular node, or AV node.
AV node, where's that?
It's located down low in the right atrium, near the septum, right above the ventricles. This node is like a gatekeeper.
Gatekeeper.
Yeah, remember that fibrous cardiac skeleton we talked about? It acts as an electrical insulator between the atria and ventricles. The only normal electrical connection across that barrier is through the AV node.
Ah, so the signal has to go through there.
It has to. And the AV node does something really important. It deliberately slows the signal down for a fraction of a second.
Why slow it down?
It creates a crucial delay. This pause allows the atria enough time to fully contract and empty their blood into the ventricles before the ventricles get the signal to start contracting.
Perfect timing. Ensures efficient filling.
Exactly. Without that AV nodal delay, the atria and ventricles might contract too close together, reducing pumping efficiency. So after that brief pause at the AV node, the signal is ready to hit the ventricles. It travels rapidly down a specialized pathway called the bundle of His,
Bundle of his.
which then splits into a right bundle branch and a left bundle branch running down either side of the interventricular septum.
Like electrical highways.
Pretty much. And finally, these bundle branches fan out into an intricate network of specialized conduction fibers called Purkinje fibers.
Purkinje fibers.
These spread throughout the ventricular muscle walls, delivering the electrical charge directly and very quickly to all the ventricular muscle cells,
Triggering the big squeeze.
triggering that powerful coordinated ventricular contraction system that pumps blood out to the lungs and body.
That is such an elegant system. SA node, atria, AV node delay, bundle branches, Purkinje fibers, ventricular contraction. Wow.
It's beautifully orchestrated.
And this electrical activity, this whole cycle, determines our heart rate, right? How fast it beats.
Fundamentally, yes. The rate at which the SA node fires sets the basic pace.
So what's a typical rate?
For a resting adult, it's typically somewhere between 60 and 100 beats per minute.
60 to 100.
A newborn baby's resting rate can be much faster, maybe around 129 BPM, and it gradually decreases as they get older.
And athletes.
Well-trained athletes often have lower resting heart rates, sometimes well below 60 BPM. That's called bradycardia. But in their case, it's usually a sign of a very efficient heart.
Because each beat pumps more blood.
Exactly. During exercise, though, the rate can really climb, maybe up to 150 BPM or even higher, potentially reaching 200, 220 BPM during maximal exertion in young, healthy individuals.
So what influences that rate? Why does it speed up or slow down?
Many factors play a role. It's not just the SA node acting alone. The rate is constantly being adjusted by our nervous system and hormones.
So the brain's involved.
Absolutely. We have cardiovascular control centers located in the brainstem, specifically in the medulla oblongata. These centers manage the balance between the sympathetic and parasympathetic nervous system's influence on the heart.
Fight or flight versus rest and digest.
Essentially, yes. The sympathetic nerves release norepinephrine, which acts like an accelerator pedal. It speeds up the SA node firing and increases contractility.
Making the heart beat faster and harder.
Right. The vagus nerve, which is part of the parasympathetic system, acts like the brake pedal. It releases acetylcholine, which slows down the SA node firing, decreasing the heart rate.
Accelerator and brake.
A constant interplay. And these control centers in the brain get input from various sensors around the body.
Sensors. Like what?
Well, there are baroreceptors. These are stretch receptors located in major blood vessels like the aorta and carotid arteries, and even in the heart walls themselves.
What do they sense?
They sense blood pressure and how much the vessel walls are being stretched. If your blood pressure suddenly goes up, these baroreceptors fire more signals to the brain.
Telling it to slow down.
Exactly. The brain responds by decreasing sympathetic stimulation and increasing parasympathetic vagal stimulation to the heart, which helps lower the heart rate and blood pressure back towards normal.
Clever feedback loop. Any other sensors?
Yes, chemoreceptors. These are located mainly in the carotid bodies, in your neck, and aortic bodies, near the aorta.
Chemo. They sense chemicals.
Right. They monitor the levels of oxygen, carbon dioxide, and the acidity, pH in your blood.
Why is that important for heart rate?
Well, if your blood oxygen level drops too low, or CO2 gets too high, or the blood becomes too acidic.
The body needs more oxygenated blood circulating.
Precisely. The chemoreceptors signal the brain centers, which then increase sympathetic output to speed up the heart rate and hopefully improve oxygen delivery and CO2 removal.
So blood pressure sensors, chemical sensors. What else affects heart rate?
Oh, lots of things.
Yeah.
Your level of physical fitness, obviously. Age plays a role. Body temperature, fever usually increases heart rate. Your emotional state, anxiety, fear, excitement, all rivet up via the sympathetic system.
Adrenaline rush.
Exactly. Hormones are big players, too. Epinephrine, adrenaline, and norepinephrine from the adrenal glands have a direct effect. Thyroid hormones also influence heart rate.
Okay.
And even the balance of electrolytes in your blood ions like calcium, potassium, and sodium can affect the heart's electrical activity and rate. It's a complex interplay of many factors, all aimed at matching the heart's output to the body's needs at any given moment.
Wow, the heart really sounds like this incredible, self-regulating masterpiece of engineering, so finely tuned. But inevitably, things can go wrong. I know heart disease is a huge global health issue.
It's absolutely true. Cardiovascular diseases, which is the broad term encompassing conditions affecting the heart and blood vessels, are unfortunately the leading cause of death worldwide.
Leading cause. Still.
Accounted for roughly 30% of all deaths globally back in 2008, and that trend continues. The majority are non-communicable, meaning not infectious, and often linked to lifestyle factors.
Like diet, smoking, lack of exercise.
Exactly. And they tend to become more common as people age. Specialists who focus specifically on heart diseases are called cardiologists,
Right.
though obviously many other medical professionals are involved in prevention, diagnosis, and treatment. So let's maybe unpack some of the most common problems. A big one is ischemic heart disease.
Ischemic, meaning lack of blood flow.
Precisely. It's also commonly known as coronary artery disease, or CAD.
Ah, problems with those coronary arteries we talked about.
Exactly. It's usually caused by atherosclerosis.
The buildup of plaque.
Right, that buildup of fatty material, cholesterol, inflammatory cells, called plaques, along the inner walls of the coronary arteries. This narrows the arteries.
Restricting blood flow to the heart muscle.
Correct. When the heart muscle doesn't get enough oxygen-rich blood, especially during exertion, it can cause chest pain or pressure, known as angina, or sometimes just shortness of breath.
Angina. Okay.
Now, if one of those plaques suddenly ruptures or cracks open,
Trouble.
big trouble. A blood clot can form right on top of it, potentially blocking the artery completely.
And that's a heart attack.
That's a myocardial infarction, or MI, commonly called a heart attack. A portion of the heart muscle is starved of oxygen and starts to die. It can also trigger certain cardiac arrest if the electrical system gets disrupted.
Scary stuff. Risk factors.
The big ones are smoking, obesity, high blood pressure, uncontrolled diabetes, and high cholesterol levels, particularly LDL or bad cholesterol. Family history plays a role too.
Okay, so that's coronary artery disease. What about heart failure? That term sounds really serious, like the heart just stops.
It is very serious, but failure doesn't mean the heart has stopped completely. It means the heart muscle has become weakened or stiff and can't pump enough blood to meet the body's demands effectively.
Oh, it's struggling to keep up.
Exactly. People with heart failure might experience symptoms like shortness of breath, especially when lying flat or exerting themselves, fatigue, and swelling in the ankles or legs due to fluid buildup.
What causes it?
It often results from damage caused by other conditions, most commonly ischemic heart disease, like a previous heart attack, long-term high blood pressure, or problems with the heart valves.
Okay.
It can involve weakness of the heart muscle's pumping action, that's called systolic heart failure, or it can involve stiffness, where the heart can't relax and fill properly, that's diastolic heart failure. It can affect the left side, the right side, or usually both.
And it increases risk of other things.
Yes, people with heart failure are at a significantly higher risk of developing dangerous heart rhythm problems, arrhythmias, than there are cardiomyopathies.
Cardiomyopathy, disease of the heart muscle itself.
Exactly. These are diseases that primarily affect the myocardium. They can cause the muscle to thicken abnormally, making the chambers smaller and stiffer. That's hypertrophic cardiomyopathy.
Okay.
Or the heart can become enlarged, stretched out, and weakened. That's dilated cardiomyopathy. Or it can become generally stiff without necessarily thickening restrictive cardiomyopathy. Or there's a type where fatty tissue replaces muscle, making the heart prone to dangerous rhythms, arrhythmogenic cardiomyopathy.
Are these genetic?
Often, yes. Many forms have a genetic basis, and they can eventually lead to heart failure if they progress.
What about the valves we talked about earlier, those crucial one-way gates? Can they cause problems on their own?
Absolutely. That falls under valvular heart disease. This happens when one or more of the heart valves don't work properly.
How so?
Two main ways. The valve opening can become narrowed and stiff, restricting forward blood flow. That's called stenosis.
Stenosis, like a bottleneck.
Exactly. Or the valve doesn't close tightly, allowing blood to leak backward. That's called regurgitation or insufficiency.
Leaky valve.
Right. Either problem makes the heart work harder to circulate blood effectively. It can cause breathlessness, fainting spells, chest pain, or fatigue. But sometimes, especially early on, it might not cause obvious symptoms and is only detected when a doctor listens to the heart with a stethoscope.
And here's something unusual.
Yes, they might hear an abnormal sound called a heart murmur.
Ah, a murmur indicates a valve problem.
It can, yes. Murmurs are basically sounds of turbulent blood flow, often caused by damaged valves, but sometimes they can be innocent.
What causes valve disease?
In developed countries, it's often due to age-related wear and tear, calcification, or sometimes damage from infections like endocarditis, an infection of the heart lining and valves.
Okay.
In some parts of the world, rheumatic heart disease is still a major cause.
Rheumatic, from rheumatic fever.
Exactly. It's an inflammatory condition that can develop after a strep throat infection, and it can permanently damage the heart valves years later.
Okay, so arteries, muscle, valves. What about that intricate electrical system? Can it go haywire?
Indeed, it can. Problems with the heart's rhythm are called arrhythmias.
Arrhythmias, irregular heartbeat.
Right. Sometimes they cause no symptoms at all. Other times, people might feel palpitations like skipped beats or fluttering or dizziness, fainting, or breathlessness.
Are they dangerous?
Some can be quite dangerous. For example, atrial fibrillation or AFib, where the atria quiver chaotically instead of beating effectively,
Uh-huh.
doesn't immediately threaten life, but it significantly increases the risk of blood clots forming in the atria, which can travel to the brain and causes stroke.
Wow, okay.
Arrhythmias can be broadly categorized as too slow, called bradycardias. These might be caused by a problem with the SA node firing too slowly, or damage to the conduction system, like the AV node, blocking signals,
Heart block.
right heart block. Or they can be abnormally fast tachycardias. These can originate from the atria, like AFib or atrial flutter, or, more dangerously, from the ventricles.
Ventricular tachycardia.
Yes, like ventricular tachycardia, VT, or ventricular fibrillation, VF. VS is the most dangerous. The ventricles just quiver chaotically. No effective pumping occurs. It causes cardiac arrest and is fatal within minutes, if not treated immediately with defibrillation.
That's the shock paddles.
Exactly. The electrical shock aims to reset the heart's rhythm. Other conditions exist too. There's pericardial disease, affecting that outer sac. It can become inflamed pericarditis,
Okay.
or fluid can build up excessively in the pericardial space, a pericardial effusion. If enough fluid accumulates quickly, it can squeeze the heart and prevent it from filling properly.
Squeeze the heart.
Yeah, that's a life-threatening emergency called cardiac tamponade.
Okay.
And then, of course, there are congenital heart defects.
Problems someone's born with.
Exactly.
Yeah.
Structural abnormalities of the heart or major blood vessels that are present at birth, they range hugely in severity. Some are relatively minor, like a small hole between the chambers, atrial septal defect, ASD, or ventricular septal defect, VSD, sometimes called a hole in the heart. Others are very complex and life-threatening, requiring surgery soon after birth.
Okay.
Some congenital defects are called cyanotic defects because they allow deoxygenated blue blood to mix with oxygenated red blood being pumped to the body, giving the skin a bluish tint. And finally, a less common but important category are channelopathies.
Channelopathies. Ion channels.
Precisely. These are typically inherited genetic disorders that affect the tiny protein channels in heart cell membranes that control the flow of ions, like sodium, potassium, and calcium.
The things that create the electrical signal.
Exactly. Disrupting these ion flows can make the heart susceptible to dangerous arrhythmias, even if the heart structure looks completely normal. They can explain some cases of sudden unexplained death, especially in young people.
Examples.
Long QT syndrome is probably the most well-known. Brugada syndrome is another, which is a significant cause of sudden cardiac death, particularly in young men in some populations.
That is a lot of potential problems. With so much going on inside, how do doctors figure out which issue is happening? What are the diagnostic tools?
Diagnosis is usually a step-by-step process. It always starts with taking a thorough medical history, asking about symptoms, family history, risk factors.
Listening to the patient.
Crucial. Followed by a physical cardiac examination. This involves looking for any signs, feeling the chest for the heartbeat location or any vibrations, palpation, and very importantly, listening to the heart and lungs with a stethoscope, auscultation.
Listening for those heart sounds.
Exactly. They'll check your pulse rate and rhythm, check your blood pressure, and listen carefully for the heart sounds. As we mentioned, normal hearts usually have two main sounds. S1, lub, from the closing of the AV valves,
Mitral and tricuspid.
and S2 from the closing of the semilinear valves.
Aortic and pulmonary.
Right. But sometimes doctors might hear extra sounds, like a third heart sound, S3, or fourth heart sound, S4, which can indicate certain types of heart problems, often related to filling issues or stiffness. And they listen for those heart murmurs, those abnormal whooshing or swishing sounds between the normal beats, which can point towards valve problems or sometimes holes between chambers. Blood tests are also incredibly important.
What can blood tests tell you about the heart?
A key one is troponin. Troponin is a protein found in heart muscle cells that gets released into the bloodstream when the muscle is damaged, like during a heart attack.
So high troponin means heart damage.
It's a very sensitive and specific biomarker for myocardial injury, yes. It starts to rise within a few hours. Another blood test measures BNP, or brain natriuretic peptide.
BNP.
Yeah, it's a hormone released by the heart muscle when it's stretched, particularly in heart failure. Higher levels suggest the heart is under strain.
Useful for diagnosing heart failure, then.
Very useful. Other blood tests check for things like anemia, which can strain the heart, electrolyte imbalances, which can affect rhythm, kidney function, and of course risk factors like cholesterol levels and blood sugar for diabetes. Now, a cornerstone of cardiac diagnosis, what's fascinating here is the electrocardiogram, or ECG, sometimes called EKG.
The ECG, the squiggly lines on the monitor.
Those very lines. By placing electrodes, little sticky pads, on the skin of your chest, arms, and legs, doctors can record the electrical activity of your heart from different angles.
Capturing that electrical wave we talked about.
Exactly. It visualizes the depolarization and repolarization waves as they travel through the heart muscle. It shows up as characteristic waves. The P wave, atrial depolarization, the QRS complex, ventricular depolarization, and the T wave, ventricular repolarization.
PQRST.
Right. And the shape, sizes, and timing of these waves and the intervals between them provide a huge amount of information.
What can it detect?
Oh, lots. It's invaluable for detecting arrhythmias. Is the rhythm too fast, too slow, irregular? Is there evidence of a heart attack, current or previous? Is there strain on the heart muscle? Problems with the conduction system?
So powerful from just surface electrodes.
It really is. Sometimes, though, an arrhythmia or problem might only occur intermittently or during activity.
So a resting ECG might look normal.
Exactly. In that case, they might do an exercise stress test, have you walk on a treadmill while monitoring your ECG and blood pressure.
To see if stress brings out the problem.
Precisely. Or they might have you wear a portable ECG monitor called a Holter monitor for 24 or 48 hours, or even longer with newer devices, to try and capture infrequent rhythm disturbances during your normal daily life.
Yeah.
Finally, imaging methods give doctors a direct look inside.
Pictures of the heart.
Yes. The most common is the echocardiogram, often just called an echo.
That's an ultrasound, right?
Exactly. It uses sound waves to create moving pictures of your heart. It's non-invasive and provides a wealth of information.
Like what?
It can show the size and thickness of the heart chambers, how well the heart muscle is contracting, how the valves are opening and closing, whether there's any valve leakage or narrowing. It can detect fluid around the heart, blood clots, tumors.
Wow, really versatile.
Very. It can even measure how much blood the left ventricle pumps out with each beat. That's called the ejection fraction, or EF. It's a key measure of overall heart function, especially in heart failure.
Ejection fraction. Okay. Other imaging.
Sometimes the chest x-ray is done, which can show the overall size and shape of the heart and whether there's fluid buildup in the lungs, a sign of heart failure. Cardiac CT scans, or cardiac MRI, can provide very detailed anatomical images. And sometimes more invasive procedures like cardiac catheterization are needed.
Catheterization. That's putting tubes inside.
Yes. Thin tubes, called catheters, are inserted into blood vessels, usually in the wrist or groin, and guided up to the heart. It allows doctors to measure pressures inside the heart chambers directly, inject dye to visualize the coronary arteries, angiography to look for blockages, and sometimes even perform treatments at the same time.
Okay, so we have this range of potential problems and a really sophisticated toolkit for diagnosis. Once a problem is identified, what are the modern ways we actually treat heart disease? How do we fix things?
Treatment strategies are really varied and depend heavily on the specific condition, its severity, and the individual patient. But they generally fall into a few categories: lifestyle changes, medications, procedures, and surgery.
Makes sense. Let's start with ischemic heart disease, the blockages.
Right. For symptoms like angina, medications are often the first line. Nitroglycerin, often taken as a spray or tablet under the tongue, can quickly widen blood vessels to relieve chest pain.
Okay.
Beta blockers and calcium channel blockers are used long-term to reduce the heart's workload and oxygen demand, helping to prevent angina episodes.
Managing symptoms. What about preventing heart attacks?
Crucial preventative measures include antiplatelet drugs like aspirin or others like clopidogrel, which help prevent blood clots from forming on those plaques,
Thinning the blood a bit?
making it less sticky, essentially. Statins are medications used to lower cholesterol levels, which help stabilize plaques and slow down atherosclerosis. And of course, managing blood pressure and diabetes effectively and absolutely stopping smoking are critical lifestyle interventions.
So, lifestyle and meds first. What if that's not enough? Or if there's a major blockage?
If medications aren't controlling symptoms adequately, or if tests show significant blockages putting the patient at high risk, doctors might move to revascularization procedures, ways to restore blood flow.
Revascularization, opening things up.
Exactly. A common one is percutaneous coronary intervention, or PCI. You might know it better as angioplasty with stenting.
Angioplasty and stents. I've heard of that.
Yeah, it's done during cardiac catheterization. A thin wire with a tiny balloon on the tip is guided to the blockage. The balloon is inflated, squashing the plaque against the artery wall to widen the opening.
Just the balloon.
Usually after inflating the balloon, they deploy a stent, a tiny expandable metal mesh tube, which is left in place to act like scaffolding, holding the artery open long term. Some stents are even coated with medication to help prevent the artery from narrowing again.
Wow. Less invasive than surgery.
Much less invasive. But for patients with multiple severe blockages or blockages in certain locations, open heart surgery might still be the better option. That's coronary artery bypass graft surgery, or CABG.
Bypass surgery, going around the blockage.
Precisely. Surgeons take a healthy blood vessel, often a vein from the leg or an artery from the chest wall, and graft it onto the coronary artery, creating a detour around the blocked section, restoring blood flow downstream.
Okay, so that's for blocked arteries. What about valve problems?
Valvular heart disease, if severe enough to cause symptoms or strain the heart, often requires intervention to repair or replace the damaged valve.
Repair or replace.
Traditionally, this meant open heart surgery. Surgeons could sometimes repair the existing valve, reshaping it or patching holes. Or, more commonly, they would remove the damaged valve and replace it with a mechanical valve.
Made of metal.
Usually durable materials like pyrolytic carbon. They last a long time but require lifelong blood-thinning medication, anticoagulation, to prevent clots.
Czar.
Or a biological valve, also called a tissue valve, usually made from processed cow, bovine, or pig, porcine heart tissue.
Animal tissue.
Yeah. These don't typically require long-term anticoagulation, but they don't last as long as mechanical valves, maybe 10, 20 years, and might need replacing eventually.
So trade-offs. Is surgery still the main way?
Open heart surgery is still common, but especially for aortic valve stenosis in older or higher-risk patients, less invasive techniques are becoming increasingly popular. The main one is transcatheter aortic valve replacement, or TAVR.
TAVR. How does that work?
It's amazing, actually. A new valve, compressed onto a catheter, is inserted through an artery, usually in the leg, and guided up to the heart. Once in position inside the diseased aortic valve, the new valve is expanded, pushing the old valve leaflets aside and taking over its function.
Without opening the chest.
Exactly. It's a game changer for patients who might be too frail for traditional open heart surgery. Similar techniques are being developed for other valves, too.
Incredible advances. Now, what about those irregular rhythms, the arrhythmias? How are they treated?
Treatment depends on the type of arrhythmia and how serious it is. Some might not need specific treatment beyond managing underlying causes. Others are treated with antiarrhythmic drugs.
Drugs to control the rhythm.
Yes, these medications work in various ways, often by affecting those ion channels we discussed, to try and restore or maintain a normal sinus rhythm, or at least control the heart rate if the rhythm can't be normalized.
Okay.
For conditions like atrial fibrillation that increase stroke risk, anticoagulant medications, blood thinners like warfarin or newer agents, are absolutely crucial to prevent clot formation.
Right, preventing stroke is key in AFib.
Definitely. For some tachycardias, fast rhythms, that don't respond well to drugs or cause significant symptoms, a procedure called catheter ablation is often very effective.
Ablation, what does that involve?
Again, using catheters guided to the heart. But this time, specialized catheters are used to identify the tiny area of heart tissue that's triggering or sustaining the abnormal rhythm.
Find the trouble spot.
Exactly. And then energy, usually either radiofrequency energy, heat, or cryoenergy, freezing, is delivered through the catheter tip to destroy or ablate that small area of abnormal tissue.
Creating a scar to block the bad signal.
Precisely. It can be curative for many types of tachycardias. Sometimes, if someone's in a fast, unstable rhythm, an external electric shock, called cardioversion, can be delivered using paddles on the chest to try and shock the heart back into a normal rhythm instantly. Now, for rhythms that are too slow bradycardias, the main treatment is often a pacemaker.
Implanting a device.
Yes, a pacemaker is a small, battery-powered device, usually implanted under the skin near the collarbone. It has one or more thin insulated wires, called leads, that are threaded through veins into the heart chambers.
What do the leads do?
They sense the heart's own rhythm. If the heart beats too slowly or pauses too long, the pacemaker sends out tiny electrical impulses through the leads to stimulate the heart muscle and make it contract, ensuring a minimum heart rate.
So it provides a safety net.
Exactly. Modern pacemakers are very sophisticated, only pacing when needed.
And what about those really dangerous, life-threatening fast rhythms like ventricular fibrillation?
For patients at high risk of those rhythms, maybe they've survived a cardiac arrest or have certain types of heart failure or genetic conditions, the treatment is often an implantable cardioverter defibrillator, or ICD.
ICD, like a pacemaker but more powerful.
It often includes pacemaker functions, yes, but its main job is different. It constantly monitors the heart's rhythm. If it detects a dangerously fast ventricular rhythm like VT or VF,
It delivers a shock.
exactly, it automatically delivers a high-energy electrical shock directly to the heart muscle through its leads, aiming to terminate the lethal arrhythmia and restore a normal rhythm. It's like having an emergency defibrillator inside you.
Life-saving technology.
Truly life-saving for many people.
Okay, one more major category. Heart failure. When the pump just can't keep up, what are the treatment approaches there?
Managing heart failure is complex and focuses on relieving symptoms, slowing down the progression of the disease, and improving quality and length of life. Medication is the cornerstone.
What kinds of meds?
Diuretics, often called water pills, help the body get rid of excess fluid, which reduces swelling and eases breathing difficulties.
Okay.
Then there are several classes of drugs proven to help the heart work better and live longer in heart failure. These include beta blockers, ACE inhibitors, ARBs, angiotensin receptor blockers, and newer drugs like ARNs, angiotensin receptor neprilysin inhibitors, and SGLT2 inhibitors.
Lots of options. They work in different ways.
Yes, they generally work by reducing strain on the heart, blocking harmful hormonal responses, and improving the heart's structure and function over time. It's usually a combination of several medications.
Are there device therapies for heart failure too?
Sometimes. In certain patients with heart failure, particularly if the left and right ventricles aren't contracting in sync, a specialized type of pacemaker called cardiac resynchronization therapy, or CRT, can be helpful.
CRT, how's that different?
It usually involves pacing leads in both the right and left ventricles. By pacing both sides simultaneously, it helps them contract together more efficiently, improving the overall pumping function. Often, CRT is combined with an ICD in one device, CRTD.
Improving the coordination.
Exactly. For patients with very severe end-stage heart failure who aren't responding well to medications or other therapies, well, the options become more limited and drastic.
Like?
One option might be a ventricular assist device, or VAD.
VAD, a mechanical pump.
Yes, it's a surgically implanted mechanical pump that helps the weakened ventricle, usually the left, pump blood to the rest of the body. It can be used as a bridge to keep someone alive while they wait for a heart transplant, or sometimes as destination therapy, a long-term solution for patients who aren't eligible for a transplant.
So it takes over some of the heart's work.
It does. And the ultimate treatment for end-stage heart failure, of course, is a cardiac transplant.
Replacing the whole heart.
Replacing the diseased heart with a healthy heart from a deceased donor. A major operation, obviously, with its own risks, and the need for lifelong immunosuppression medication to prevent rejection. But it can offer a dramatic improvement in survival and quality of life for carefully selected patients.
It's just staggering how complex the heart is and how far medicine has come in understanding and treating it. But thinking back, what did people understand about the heart throughout history? Did they always know it was this intricate pump? Or did our view of it evolve dramatically?
Oh, dramatically is an understatement. Humans have obviously known about the heart since ancient times. You can feel it beating, but its actual function was deeply misunderstood for, well, most of human history.
So what did they think it did?
In many early societies, views were primarily religious or philosophical, not scientific. The ancient Greeks, though, were really pivotal in starting to think about it scientifically. Aristotle, for instance, thought the heart actually created the blood.
Created it. Wow.
Yeah. Plato saw it as the source of circulating blood, which was closer. And Hippocrates, the father of medicine, noted blood circulating cyclically from the body through the heart to the lungs. Some early progress there.
So some glimmers of understanding.
Yes, and Erasistratos, another Greek physician around the 3rd century BCE, even noted the heart acted as a pump and discovered the heart valves.
He discovered the valves way back
He
then.
did, but he also mistakenly believed that arteries were filled with air, not blood. So close, but not quite there. But then, for almost 1,000 years, maybe more, the dominant view came from Galen.
Galen, the Roman physician.
That's the one, lived in the 2nd century CE. His influence was immense and lasted well into the Renaissance. He knew vessels carried blood. He correctly distinguished between the darker venous blood and the brighter arterial blood.
Okay, so he got some things right.
He did. He also concluded the heart was the hottest organ in the body, providing heat to everything else. But here's where he went wrong on the mechanics. He believed the heart sucked blood in during diastole relaxation.
Sucked it in, not pumped it out.
Right. And he thought it was the pulsation of the arteries themselves that moved blood around, not the heart's pumping action driving it.
Interesting.
He also had this idea that arterial blood was created when venous blood passed through tiny invisible pores in the septum between the ventricles.
Pores in the wall. We know that's solid muscle now.
Exactly. He thought venous blood seeped through, mixed with pneuma or air drawn in from the lungs via the pulmonary vein, and became arterial blood. These ideas, though incorrect, were accepted as medical dogma for centuries.
Wow. So when did we finally figure out it was a pump pushing blood in a circuit?
The huge revolutionary breakthrough came in 1628
1628.
with an English physician named William Harvey. He published a book called De Motu Cordis on the motion of the heart and blood.
De motu cordis. Sounds important.
Monumentally important. Based on careful experiments and observations, Harvey completely described the systemic circulation, how blood is pumped by the heart out through arteries and returns through veins in a continuous loop. He demonstrated the mechanical pumping force of the heart.
Overtuning Galen completely.
Fundamentally, yes. It was a paradigm shift in physiology. It took time to be fully accepted, but Harvey laid the foundation for modern understanding. Later, much later, in the early 20th century, scientists like Otto Frank and Ernest Starling,
Frank and Starling, we heard their names earlier.
right, working independently, they did key experiments that helped explain the mechanics of how the heart muscle contracts and responds to stretch, leading to that Frank-Starling mechanism we discussed, how the heart adjusts its pumping force. And the electrical system, the conduction pathway.
Right.
When was that figured out?
Yeah, when did we understand the SA node and all that?
That was also largely an early 20th century discovery. A Japanese pathologist, Sunao Tawara, published a monograph in 1906, meticulously describing the conduction system, including discovering the AV node.
The AV node, the gatekeeper.
Yep. Tawara's work spurred others, like Sir Arthur Keith and Martin Flack in Britain, who soon after discovered the SA node, the natural pacemaker.
So the key components were identified then.
Right around that time,
Yeah.
yes. And these anatomical discoveries provided the crucial basis for understanding the electrocardiogram, the ECG.
Which was invented when?
Invented by a Dutch physiologist, Willem Eindhoven. He developed the first practical string galvanometer ECG machine and identified the P, QRS, and T waves. He won the Nobel Prize for it in 1924, a truly transformative diagnostic tool.
Amazing how these discoveries built on each other. And heart transplants, that feels like a much more modern marvel. When did that become possible?
It is definitely a modern marvel. The very first attempt at a heart transplant in a human was actually done by James Hardy in the U.S. in 1964 using a chimpanzee heart.
A chimpanzee heart.
Yes. Unfortunately, the patient only survived for about 2 hours due to the massive rejection.
Right.
The first successful human-to-human heart transplant, the one that really made headlines worldwide, was performed in 1967.
1967.
Where? By Dr. Christian Barnard in Cape Town, South Africa. The patient, Louis Washkansky, lived for 18 days before succumbing to pneumonia, likely related to the immunosuppression. It was a landmark event, captured global attention.
I can imagine, but survival was still short then.
Initially, yes. Long-term survival rates were quite low in the early years, mainly due to rejection and infection. But pioneers, notably Dr. Norman Shumway and his team at Stanford University, made huge strides in refining the surgical techniques and developing better immunosuppressive drug regimens through the 1970s and 80s.
Making it a viable long-term therapy.
Exactly. By the year 2000, over 55,000 heart transplants have been performed worldwide. And innovation continues. What's fascinating here is that just in 2022,
Yes.
Dr. Bartley P. Griffith performed the first successful transplant of a genetically modified pig heart into a human patient.
A pig's heart. Genetically modified how?
Modified to reduce the chances of rejection. The patient lived for over a month with the pig heart functioning. It's still early days for xenotransplantation, but it represents a potential future direction to address the shortage of human donor organs. It's sobering to think, though, that by the mid-20th century, heart disease had sadly overtaken infectious diseases as the #1 killer in the United States.
And it still is globally, you said?
It still is, yes.
Yeah.
But ongoing research, like the landmark Framingham Heart Study, which started way back in 1948 and followed generations of residents in Framingham, Massachusetts, has been absolutely crucial in identifying risk factors like smoking, high blood pressure, and cholesterol, and understanding how lifestyle influences heart health. That knowledge is key to prevention.
Absolutely. But beyond the vital science and medicine, the heart has always held this incredible symbolic meaning across practically every culture, hasn't it?
Oh, profoundly so. This raises an important question. Why? Why is the heart so universally seen as, well, the center of our being.
Yeah, why the heart and not the brain, for instance?
Well, for millennia, the heart's constant palpable beating made it seem like the very source of life itself. So it became identified not just with life, but with emotion, courage, reason, will, intellect, basically, the mind or soul. The brain's role wasn't understood until much later.
So the heart got credit for everything.
Pretty much. It's a powerful emblematic symbol in so many religions. In Islamic and Judeo-Christian thought, it often signifies truth, conscience, moral courage. In Hinduism, it's seen as the divine center within. In Buddhism, a symbol of purity. Look at language. In the Hebrew Bible, the word lev means heart, but it's used metaphorically for emotion, the mind, the whole inner person.
Interesting.
The ancient Egyptians had a fascinating belief. They thought the heart, which they called Ib, was formed from a single drop of the mother's blood at conception.
Wow.
And they saw it as the absolute seat of emotion, thought, will, and intention. It was so crucial that it was the only major organ left inside the body during mummification, because they believed that in the afterlife, the heart would be weighed on a scale against the feather of Mut, the goddess of truth and justice. If your heart was heavy with sin, you faced oblivion. If it balanced, you achieved eternal life.
Incredible a significance.
Absolutely. In Chinese culture, too, the character for heart also carries metaphorical meanings like mind, intention, or core. It's seen as the center of spirit and consciousness. The Sanskrit word for heart, hodben, similarly refers to both the physical organ and mind, or soul. And many classical philosophers, Aristotle included, firmly believed the heart, not the brain, was the seat of thought, sensation, and emotion. The brain was often seen as just a cooling mechanism for the blood.
Funny how wrong they were about the brain.
Completely. Even the Aztecs had a strong heart-centric view. They called the heart tona, saw it as the seat of the individual soul and containing a fragment of the sun's heat.
Which explains the heart sacrifices.
Exactly. Extracting the heart was seen as a way to offer the most precious life force back to the gods, particularly the sun god, to ensure the sun would continue to rise.
A brutal but culturally significant connection.
Very. And what's fascinating here, connecting the ancient to the modern, is that even today, you hear indigenous leaders from cultures around the world,
Yes.
from Alaska to Australia, calling for humanity to make a shift from the mind to the heart. They speak of the heart not just emotionally, but as a source of deeper wisdom, intuition, and profound interconnectedness with each other and the planet.
So that symbolic meaning persists very strongly.
It really does.
And of course, it's everywhere in everyday language and symbols, isn't it?
Absolutely. Think about it. A broken heart for grief or loss, wearing your heart on your sleeve, having a change of heart, learning something by heart, Cupid's arrows striking the heart for romantic love, the ubiquitous heart symbol, though it doesn't really look much like the anatomical heart.
True. Where did that shape come from?
That's debated. Theories range from stylized ivy leaves to seed pods, or even certain parts of human anatomy. But it's become the universal shorthand. Even the Georgian alphabet has a letter that looks like and is often used as a heart symbol. And think about religious iconography, like the veneration of the Sacred Heart of Jesus in Catholicism, representing divine love and suffering. It's deeply, deeply ingrained.
It's clear the human connection to the heart runs incredibly deep, scientifically, historically, culturally.
Yeah.
But as amazing as our heart is, it's just one version out there in the animal kingdom, right? How do hearts differ across species? Is it always this four-chambered pump we've spent so much time describing?
Not at all. There's incredible diversity. First off, size varies enormously. You go from a tiny mouse heart, maybe 12 milligrams,
Tiny.
all the way up to the heart of a blue whale, which can weigh a staggering 600 kilograms.
600 kilos. Look like a small car.
Pretty much.
Yeah.
But structurally, across all vertebrates animals with backbones, the heart is generally located in the ventral part of the body, the front or underside. It's usually enclosed in a pericardium, that protective sac.
Okay.
And almost always it shows that asymmetric leftward orientation during development, why exactly it tilts left is still debated, might be related to developmental twisting events. Now, where it gets really interesting is the evolution of the chambers and the circulatory system itself. We have a four-chambered heart, which provides complete separation of oxygenated and deoxygenated blood.
Right. Very efficient.
Very efficient, especially for warm-blooded animals like us mammals and birds
Yeah.
who have high metabolic demands. But many adult amphibians, like frogs and most reptiles, like lizards and snakes,
Yes.
they have what's called a double circulatory system, meaning separate circuits for the lungs and the body, but they typically only have a three-chambered heart.
3 chambers. How does that work?
They have two atria, receiving blood from the body and the lungs, respectively, just like us. But they only have one ventricle.
One ventricle, so the oxygenated and deoxygenated blood mixes.
Some mixing does occur in that single ventricle, yes. Blood from both atria empties into it, and then the single ventricle pumps blood out simultaneously to both the pulmonary circuit, lungs, and the systemic circuit, body.
Doesn't seem as efficient.
It's less efficient than complete separation, certainly. However, in most reptiles, the ventricle has internal ridges and partial septa that help direct the flow, minimizing the actual amount of mixing. It's not just a complete swirl. And crocodiles are a fascinating exception.
Crocodiles?
Crocodiles and alligators, they actually do have a fully divided four-chambered heart, much like birds and mammals.
Really? So they evolved it separately?
That's the thinking, yes.
Yeah.
This complete four-chambered structure seems to have evolved independently in the archosaur lineage, which includes crocs and birds, and in the mammal lineage. It's an example of convergent evolution and different groups arriving at the same efficient solution. Though even in crocodilians, there's a little twist. They have a small shunt, a connection called the foramina pinisa, located just outside the heart, that allows them to deliberately mix some blood between the systemic and pulmonary circuits when they need to, like during prolonged underwater dives.
Ah, so they can bypass the lungs a bit when diving?
Essentially, yes. Gives them some physiological flexibility. So it's really only in birds and mammals that the two bloodstreams, pulmonary and systemic, are permanently and completely kept separate by that solid interventricular septum.
Okay, so 3 chambers in most reptiles and amphibians, 4 in crocs, birds, and mammals. What about fish? What are their hearts like?
If we connect this to the bigger evolutionary picture, the heart likely first evolved in fish, maybe around 380 million years ago or even earlier.
Yeah.
Fish hearts are often described simply as two-chambered.
2 chambers, just an atrium and a ventricle.
Basically, yes. One atrium and one ventricle arranged in sequence. But they also have additional compartments acting as entry and exit points. Primitive fish actually had 4 structures in a row. Yeah. First, the sinus venuses collected deoxygenated blood from the body. Then it flowed into the atrium. Then into the powerful ventricle, which did the main pumping. And finally out through the conus arteriosus, which sent blood directly to the gills for oxygenation.
A single loop circuit.
Exactly. Body, heart, gills, already body. In many later fish, this linear arrangement evolved into more of an S shape within the pericardium. And those extra compartments, the sinus venusus and conus arteriosus, eventually got incorporated into the main chambers in the evolutionary line leading to amniotes, reptiles, birds, mammals.
Yeah.
Our right atrium includes remnants of the sinus venusus, for example.
So our 4 chambers evolved from that simpler fish plan.
That's the evolutionary trajectory, yes.
What about animals without backbones? Invertebrates, do they even have hearts?
Many do, yes, but their circulatory systems can be quite different. Many invertebrates, like arthropods, insects, spiders, crustaceans, and most mollusks, like snails and clams, but not squid.
Yes.
They have what's called an open circulatory system.
Open, what does that mean?
It means the circulating fluid, which is called hemolymph rather than blood.
Chemolymph.
Yeah, it often uses a copper-based molecule called hemocyanin to carry oxygen instead of our iron-based hemoglobin, which can sometimes give it a bluish tint. Anyway, this hemolymph is not always contained within vessels.
So it just sloshes around?
Kind of.
Whoa.
Deoxygenated hemolymph collects in spaces or sinuses around the heart. It then slowly permeates into the heart through small openings called ostia, which have one-way valves. The heart then pumps this fluid out, usually through a short artery, into the main body cavity called the hemocoel.
So it directly bathes the organs?
Exactly. It bathes the tissues and organs directly, delivering nutrients and oxygen before eventually collecting back near the heart to start again. It's generally a lower pressure, less efficient system than our closed circulation.
What does the heart look like in, say, an insect?
In arthropods, the heart is typically a simple muscular tube running along the dorsal side, the back. It contracts peristaltically, like a wave, to pump the hemolymph forward. Some invertebrates have even simpler setups. Earthworms, for instance, have a closed system, but oxygen travels mainly by diffusion through their skin. They don't have a single central heart, but rather 5 pairs of pulsating muscular vessels called aortic arches that connect the main dorsal and ventral blood tubes. You could think of these as multiple small hearts.
5 pairs of hearts.
Sort of, yeah. And then what's really fascinating are the cephalopods, squid, octopus, cuttlefish.
They're very active predators, right?
Incredibly active and intelligent. They have a closed circulatory system like us, but they have 3 hearts.
3 hearts.
Yep, they have 2 smaller gill hearts, or branchial hearts, one located at the base of each gill. Their job is specifically to pump deoxygenated blood through the gills to get oxygenated.
Okay, 2 hearts for the gills. Where's the third?
The third one is the main systemic heart. It receives the now oxygenated blood from the gills and pumps it powerfully out to the rest of the body.
Wow, a specialized system. Why 3?
It's thought to be an adaptation for their active lifestyle. Pumping blood through gills creates resistance, so having dedicated hearts for that task allows the main systemic heart to generate higher pressure and circulate blood more efficiently to their muscles and large brains. This really raises an important question about biodiversity, doesn't it?
It really does.
It just highlights the incredible diversity of solutions. Life has evolved to meet the fundamental challenge of circulating fluids and delivering oxygen, tailored to each organism's specific needs and environment. Hashtag tag tag outro.
Wow, what an absolutely incredible deep dive into the heart. I mean, from its precise location tucked in our chests to that intricate dance of chambers, valves, electricity, and then tracing its story through history, culture, and even across the animal kingdom. It's truly a marvel.
It really is. Understanding the heart's, basic anatomy and physiology, how it works, it doesn't just help us appreciate the miracle of how life is sustained moment to moment.
Right.
It also provides the crucial foundation for recognizing, diagnosing, and treating that whole spectrum of cardiovascular diseases
Yeah.
that affect literally millions of people around the globe.
Yeah.
We've journeyed from ancient beliefs that thought the heart was maybe filled with air or just sucked blood in,
Yeah.
all the way to groundbreaking modern therapies like KVR and heart transplants, even looking towards animal organ transplants. It just shows that continuous journey of discovery, our relentless quest to understand this absolutely vital organ.
So, thinking about all this, what does it mean for you, our listener? For me, I'm definitely left thinking about how much incredible depth and complexity there is to something we so often just take for granted, that steady beat in our chest.
Yeah.
This deep dive, it really adds a whole new layer of meaning, doesn't it, to those familiar phrases like listen to your heart, or having a change of heart, or putting your heart into something.
It certainly does.
So here's something to mull over. What new perspective does understanding the heart's literal mechanics, the plumbing, the electricity, the sheer power alongside its profound symbolic history give you? How does it change how you think about this organ that sits quite literally at the center of your being? Something to ponder until our next deep dive.